So hi everyone, I'm back. We're really going to talk about the outcomes of 6 newborns that were identified through newborn screening in what we call the modern era over the past 5 years, and their outcomes, which is a activity I'll describe that multiple people have worked on, including the authors on a paper that we're preparing, which includes Kristen Page, Margie Ream, Rangara, John, Raphael Galindo, Katie Gustafson, Malin Ho, Robert McKinstry, Ali Mian, Jim Provenzali, Jennifer Rubin, Shalini Chenoy, and myself. And we're describing work from Duke, Nationwide Children's of St. Louis, and Lurie Children's Hospital in Chicago. Next slide. Now, we had planned today to have me do an introduction and then to have Margie focus on talking about some outcomes and challenges with neurophysiologic testing, and Ali Mian to talk about neuroimaging testing. But Ali is sick and let us know this morning that he's not able to attend, and he sends his apologies, and we let him know that we hope he gets well soon. I'm going to spend 1 minute to talk about what he was going to talk about, but Margie and I will fill the rest of the time with our presentations. Next slide. So just by way of background, and you've heard a lot of this before, but we all know that early diagnosis and transplantation improves outcomes for infants with early infantile Krabbe disease. New York State pioneered screening and initially published their report of outcomes for the first 8 years, where they had screened about 3.2 million babies and identified 6 who had early infantile Krabbe disease, 2 of which were siblings. 4 of those 6 babies underwent transplant, and 2 died during transplant or shortly thereafter of complications related to transplant, and 2 are surviving with moderate to severe handicaps out now to about 15 years. Other observations, at least in New York, were that the incidence was lower than expected. Time to transplant was much longer than previously published, and outcomes were not as good as what had been previously published. But I have to point out, previously published transplants were all performed in babies born into families where there had been a prior affected sibling with Krabbe disease. So it was known to screen the pregnancy, and it was known to mobilize the troops way before that baby was born to enable referral to a transplant center. And when you're looking at newborn screening, you're approaching families whose babies screen positive, where they probably never heard of Krabbe disease. They don't know anything about the disease. They don't have the prior experience with a sick child. They have a very healthy looking newborn baby, and it's very hard to believe that that baby may really get sick. And it's hard. In fact, I can't imagine how hard it is to have to make very rapid decisions to go for some sort of very high-risk therapy because you have to believe that your baby is going to get sick and later die of the disease. Next slide. So over the past 5 years, 6 babies were identified in 4 states with early infantile Krabbe disease. And we formed, really with Kristen's support, a study group amongst these centers so that we could report the outcomes of the babies who were treated, and the people involved are listed on the slide. Next slide. So we designed a multi-center observational study. Kristen created a REDCap database at Duke that was available to all. We collected data about demographics, diagnostic studies and timelines, transplant characterization, such as timing and donor selection, preparative regimen, GVHD prophylaxis, and supportive care, transplant outcomes, which included engraftment, chimerism, and complications, and neurodiagnostic data, which we'll discuss more about today, including the electrophysiologic tests, MRI, and developmental testing. The primary endpoint of the study was looking at these measures at 1 year, but we've continued to collect additional data as these babies have continued to be followed. So we have later data on some patients, and all families consented to be part of this observational study. Next slide. So the 6 infants came from Illinois, Kentucky, Ohio, and Tennessee. They all had low GAL-C activity and screened positive on the newborn screening test. They all had elevated psychosine, and this is in the newborn dry blood spot of the 24 to 83. They were all referred for transplants. 4 remained in their home state, and 2 came to Duke. And the genotypes were varied. Not all had the 30 kb deletion, and in fact, a few had new pathogenic variants described. Next slide. So just some key points about the outcomes. The days to initiate chemotherapy. This means the baby was diagnosed, the parents were informed, the baby was referred, they were seen at the transplant center, they had a workup done to confirm their diagnosis and also stage their disease, which included MRI, and a spinal tap, EEG, nerve conduction, auditory evoke responses, and visual evoke potentials, as well as all the pre-transplant workup. And they started chemotherapy between 14 and 32 days of life. Their days to actual transplant, which is 10 days later, is 24 to 40 days of age. All babies had a cord blood transplant. All were conditioned with myeloablative chemotherapy with busulfan, cyclophosphamide, and ATG. They all had cyclosporin and MMF for GVHD prophylaxis and standard transplant care. All babies engrafted in a median of 13.5 days. The range was 11 to 24 days, which if you follow cord blood transplant is faster than a typical transplant just because these are small babies getting relatively higher doses of cells. All babies had documented donor chimerism and normal GAL-C activity in their blood after engraftment, after transplant. All babies are alive with a median follow-up or mean follow-up now 46 months. The range is out to 56 months. 4 children have normal immune function and are off all transplant-related medication. 2 are intermittently still being treated with immune suppressive therapy for autoimmune hemolytic anemia. And all children have some degree of motor disability affecting ability to walk and in some speech articulation. Next slide. Now this is work by Katie Gustafson at Duke, just looking at the neurodevelopmental outcomes at a year. And the main points I want to make from this slide are that these children, if you look at panel A, which shows you their composite scores at 1 year, where the normal would be 100, all children have some deficits in all 3 spheres, motor, language, and cognitive, but the deficits in the motor function are the most prominent. You can see on the right side, labeled B, where you see the subscales, that gross motor is the area where all babies are delayed in developing ability to walk, stand independently, etc. And although there are fine motor deficits, they're not as pronounced as the gross motor deficits. Next slide. Now, this work was done by many, many people, and the key people are shown on this slide, and I want to make sure I acknowledge them. And I'm just going to say, because Ali isn't speaking today, this is our acknowledgement slide, even though Margie is going to come on in a minute and talk with us a little bit more. So next slide. I want to just say a word, although I'm not really qualified to do it justice. about what Ali was going to speak about. So I think the main focus here is that in reviewing MRIs with a group of experts, including Ali and Jim Provenzali at Duke and Margie from Nationwide, we're learning that it's very, very difficult to really accurately interpret Krabbe disease involvement and progression on standard MRIs that are typically obtained in the clinic. And there's a scoring system called the LESS score, which was developed for ALD, which was initially applied to Krabbe, and Jim Provenzali actually published a paper about it many years ago. But that score does not really do justice to understanding the evolution of demyelination or loss of myelin or absence of myelination in the brain in babies with Krabbe disease. And Ali was going to propose two things. One, that we simplify the scoring system and look at 5 regions of the brain with a 1 to 3 point scale for each, 1 being mild, 2 being moderate, and 3 being severe, looking at the deep cerebral white matter, which includes the periventricular area and the central valley, looking at the dentate hilum, the cerebellar white matter, the thalamus, and the parietal occipital region. And he proposed a score. There's some early pre-validation exercises that have been done on the scans from the babies on this study, but really there needs to be a big data analysis to really understand the sensitivity of the score. And we're working together to kind of put together a library of scans of kids with Krabbe who've been treated at the various centers over the years, even if they weren't on this study, so that we could do that big data analysis. The good news is that there is a referral reference database of normal kids that it can be tested against. So our group is planning on carrying that activity out over the next year, I hope, but it could take longer. So I'm going to turn the podium over to Margie, who is going to talk about neurophysiologic testing and the results we have and the challenges that also poses to the process. So thanks, Margie.
Thanks, Joanne. Okay, so the same list of contributors and collaborators at the bottom here. Next slide, please. So one question that we hope to address with our study of our newborn screen identified early infantile patients who were transplanted is how should we monitor for disease activity and progression? And to try to answer this question, we are reviewing the case series of patients who were identified outside of New York State by newborn screening and transplanted by about 6 weeks of life. It's the same patients that Joanne was just talking about. Next slide. So during the course of my talk, I'll just be speaking about the neurophysiology or the electrophysiology data. So not the imaging or the developmental outcome studies. The initial neuroddiagnostic algorithm for newborn screen identified patients was extensive. And we did hear a little bit about this already. And there wasn't really enough data at the time that was proposed to prioritize the studies or assess for the long-term utility of the studies over time. Next. So the battery of testing that was proposed by Dr. in 2009 included MRI, EEG, brainstem auditory evoked responses, or BARE, visual evoked potentials, or VEPs, nerve conduction studies, CSF analysis for protein and cells, and neuropsychological testing. And these were for patients at risk for developing Krabbe. These were to be repeated at a fairly frequent basis. And through the work that Dr. Stone presented for patients that are at risk of later onset disease, we've been able to decrease the frequency of the testing for some of those patients, but it's still a pretty cumbersome set of tests for families and for healthcare systems to accommodate. Next. A few years after 2009, VEP and EEGs were no longer recommended as part of the initial evaluation for patients thought to have early infantile Krabbe disease. Next. And the extensive neurodiagnostics did not lead to diagnosis in the 9 high-risk patients who are being followed longitudinally in New York, who did not either did not end up developing disease or were lost to follow-up. And we heard more recent updated data than what was available in this 2016 paper earlier today. Next. And I mentioned the new guidelines for ongoing monitoring for the development of disease in later onset Krabbe that Dr. Stone presented. Next. Again. So we know that neurodiagnostics should not delay the initial referral for stem cell transplant. Next. But that information from neurodiagnostics that is done during the course of transplant evaluation and then over the course of following the patient longitudinally may provide some information that will help us with prognosis and eventually with evaluating new therapies. But we really need longer term data to make sense out of what we're seeing. Next. Okay. So this is a repeat of what Joanne presented for our collaborators. I just want to point out that Kristen is now at Medical College of Wisconsin, but still actively involved. Next. The data was retrospectively and is continuing to be prospectively entered into the REDCap database that Dr. Page created. Next. And the study is consented and IRB approved at each of the institutions involved. And the institutions here are the transplant centers that transplanted the 6 patients. Next. Okay. Continue on. I think that this is just a copy of what Joanne presented, so I think we can skip on to the next. Yep. Okay. And go on to the next slide, please. So this figure is showing the timeline that Joanne discussed. On the y-axis on the left is each patient 1 through 6. And on the x-axis is the patient's age in days. So all of these patients received newborn screening, and that result was reported out, at variable times, usually within the first week or week and a half or so of life. That top patient, you can see the newborn screen was reported out at about 15 days. So the goal transplant is by 30 days of life, and that's represented by the vertical gray bar. Next. But you can see here that patients were transplanted anywhere from about 3.5 weeks of age to about 40 days of age. So despite newborn screening and centers being ready to roll, so to speak, some of the transplants were quite delayed compared to the 30-day goal. Next. Our patients received a variety of pre-transplant neurophysiologic testing, and what was actually done varied by institution. And I think this is one opportunity we have, is to try to truly standardize the approach between institutions to the pre-transplant as well as post-transplant workup. So patients received the visual evoked potential, EEGs, auditory evoked responses, and nerve conduction studies. Next. The nerve conduction and brain auditory evoked potentials were abnormal in all patients in the newborn period prior to transplant, in all patients that they were done in. Next. Visual evoked potentials weren't helpful pre-transplant in correlating with abnormalities on MRI or behavioral visual responses on exam, and they're very technically difficult. So only 4 infants underwent VEP testing, and half of those studies were basically non-diagnostic just because of the technical difficulties the centers experienced with the testing. A note on the EEG, 2 of the patients here listed as normal and 4 is listed as excessive sets. So in the neurophysiology world, a set is a sharp electrographic transient, and among EEG readers, there is some debate in the field if that is an abnormality that indicates risk for seizures or just something we see in brains that are slightly more premature than we expect them to be. So in general, the EEGs in the neonatal period were not helpful. Next. And none of the patients have had seizures to date. Okay, next slide. So now we'll take a closer look at the data from the nerve conduction studies and auditory evoked potentials. Next. So a bear study is shown here on the left in this baby that has electrodes on their scalp and on their face, and then an earbud in their ear that creates little clicks or sound stimuli. And the electrodes are placed in different parts of the scalp to try to get the signal as it's passed from the ear up into the brain. And so the brain slices here show different points along the auditory pathway. And the Roman numerals correspond to waves that we record on the electrodes. Next. So here's a look at the waves, and each wave is numbered for the anatomical position it represents. And the traditional way of reporting abnormality in Krabbe patients on this study is looking at the latency, or the time it takes for the click to reach from 1, which is the ear, to 5, which is the midbrain. So this is the 1-5 latency. And if this is slower than usual, then that suggests a problem with conducting that signal along the pathway. Next. So all of our bear studies were abnormal in all patients at all time points. Next. And this is showing exactly how they're abnormal. So the dotted line is the normal latency over age. So age is on the x-axis and the 1-5 latency is on the vertical axis. The dotted line is normal. All the patients ended up abnormal. There was one patient that was teetering on the edge of normal for the first couple of studies. But what I found interesting about this data is that at least for the 2 patients that had 2 to 3 year follow-up, their abnormality seemed to stabilize and was not, at least over the course of our time points here, was not getting dramatically worse. So unfortunately, with the number of patients we have and the amount of follow-up we have, this is the extent of the data I can show you on our auditory evoked potentials. But I think it is clear that all these patients are experiencing some sort of what I consider basically a neuropathy, or a problem along their auditory pathway that reflects the demyelination that's occurring. Okay, next. So nerve conduction studies are the other test I wanted to talk about. And this picture on the right shows you what a nerve conduction study looks like. So this is just a full-size person, an adult probably, with electrodes over their thumb. And there's example of positioning, 2 different positions for the stimulating device. And the stimulating device basically gives you a little zap, and it travels down the nerve, and you measure it at the electrodes on the thumb. So you can measure the zap coming from different distances from the recording electrodes. And so you can measure how long it takes the signal to get down the arm, or whatever nerve you're testing. And you can measure how strong the signal is as it gets down there. Next. So here's a picture of the same study on a baby. And I think already you can see that this might be a little difficult. Next. So difficulty in doing nerve conduction studies on infants is that the landmarks are difficult to pinpoint. If you're palpating for a particular bony prominence to know where the nerve is, chubby little babies, is hard to feel. Even in large centers, newborn nerve conduction studies, and really nerve conduction in the first year of life, are not a high volume study. And as you know, at your own centers, the more you do of a test, the better the test taking and test recording and test reporting is. But even at large centers, this is not done that often. There's also variability between labs. Some labs, labs will report different nerves, and will use, and may even use different normal values from within their lab. And the normal values do change with age. So if we're looking at a change in the values over time, that has to be compared to the normal change over time. These are not static nerves. They do develop over the first few years of life. Next. But nerve conduction studies are good because they can help us look at the axon health, or the health of the actual nerve cell. And with that, we're looking at the amplitude or the size of the signal that gets down the nerve, as well as the health of the myelin. And the myelin helps speed up the conduction. So we're looking at what I'll be showing you in the next couple slides is amplitude and velocity. So amplitude looks at the axon, velocity looks at the myelin, and we can look at both motor and sensory nerves. And as Joanne was saying earlier, all of our patients have some degree of motor impairment. And I think with the data I'll show you, it's very clear that a lot of that is because of the motor neuropathy. Next. So despite having done many nerve conduction studies on our 6 patients, we weren't able to collect much longitudinal data. Next. And so here's how that breaks down. So we have upper extremities and lower extremities, sensory neurons and motor neurons. Different labs test different things. So not all labs, for example, tested motor neurons in the arms. So the first row in the upper and lower shows you the number of patients that were tested. So of our 6 patients, 4 or 5 had these different tests that were attempted to be performed. The next row shows the number of studies that were non-reactive in the neonates, meaning we gave the stimulation, but just couldn't record anything. And we don't know if that's because the nerves weren't healthy enough to conduct a signal that's recordable, or if just the technical challenges prevented recording of the signal. So in the neonates, we had very few recordable data points. Most of the babies had multiple studies done over time, but very few of them had multiple measures. And so those ones with multiple measures is what I'll show you next in the next slide. So one thing that I do want to point out, though, is that sensory neurons are very hard to record from because the signal is much smaller. That's recorded in microvolts, where motor is recorded in millivolts. So again, when we're interpreting the test results, I don't know if these patients have, how severe their sensory neuropathy is versus they have a sensory neuropathy and it may or may not be as severe, but because what we're recording is so small, how much is technical difficulty playing in? Next slide. So neuropathy is present and progressive. Despite the limitations that I just mentioned in our data, it's pretty clear that the neuropathy is present and progressive, and all sensory and motor nerve conduction studies were abnormal, and all patients tested at all time points tested. The legs were more affected than the arms. We see that clinically in our patients who are able to feed themselves and play with toys, but are not able to walk. Part of this is because the leg neurons are simply longer and are then more vulnerable to injury. And we also saw axonal and demyelinating components in neuropathy that worsened over time in most patients. Next slide. So sensory neuropathy. Next. In the arms, here we have percent normal for age on the vertical axis and age in months on the horizontal axis. The dotted lines show velocity, which is a measure of the myelin, and the solid lines show amplitude, which is a measure of the health of the axon itself. So in the patients that we're showing here, they all got worse over time. Next slide. In the arms. And then here in the legs, only one patient had reportable data at more than one time point. This suggests that this patient may have experienced some stabilization of their neuropathy, but look at the percent normal, it's only 20%. So this is really a severe neuropathy. Next. Now for the motor studies, motor neuropathy was present and progressive in all but 1, maybe 2 patients. So on the left is the arms amplitude, so axons, and the right is arms velocity or myelin health. And the blue patient there, which is patient 1, actually did have some improvement, but they went from very low in amplitude to slightly more measurable amplitude. And then on the right, the purple patient seemed to stabilize out to 3 years of age, but again, stably very low at 20% of normal. Next. In the legs, we had mixed results for the amplitude and somewhat stabilizing results for the velocity. And as you're looking at this, I'm sure many of you are thinking, what are they talking about? There's only 2 patients here. And you're right, there's only 2 patients reported on those lower graphs with longitudinal data. That's all we have to work with at the present time. And so hopefully as patients are identified at more centers, as more states roll out screening, we'll be able to include them in our database and get more useful information over time. Next. So if we do want to correlate some of these results with how the patients are doing clinically. Patient 1 is bearing some weight, and he or she is the one who seems to start to improve, at least in their arms. 4 and 5 are crawling, but 4 and 5 had some longitudinal data, but 4 did not. Okay, next. So some of our lessons learned, next, is that it is very difficult to do a detailed characterization of neuropathy based on our newborn screen identified patients who were transplanted early. Next. But neuropathy was apparent from birth. The auditory evoked responses were pretty clear. We were able to record those well, and they were abnormal. They got worse over time and then seemed to stabilize. I think it's hard to make similar statements about the peripheral neuropathy, but that didn't stop me from trying over the last few slides. Next. Sensory is at least harder to record than motor responses, and legs are definitely worse than the arms. Next. And there is some hints that progression of neuropathy may stabilize over time, but obviously longer follow-up is needed. Okay, next slide. And please refer back to the acknowledgements that Joanne presented. This has really been a group effort of all the centers taking care of all these patients.
Great. So thank you, Margie and